Good afternoon, ladies and gentlemen. My name is Sujata, Sawhney, and I'm a pediatric rheumatologist from India. And I'll be telling you a little bit about what we do there. Yeah, that's right.
Yes, that's
Thank
it.
You. So, ladies and gentlemen, for all of you who don't know, I work in a center called the Gangaram Hospital, which is there in Delhi, which is the capital of India. And this is a tertiary level hospital setting. It's a private hospital which is run by a trust, and it has an active postgraduate training program. We have over 100 postgraduate students, and we have 12 in pediatrics. The pediatric rheumatology unit is a new unit which we set up 5-7 years ago in New Delhi. Now, we have a large catchment population of 16 million, and as per our demographics, we have about 30% of them who are under 16. So we have a large number of 5 million children in New Delhi. The number of SLE patients followed actively per year are between 40 to 45. Now, we diagnose about 8 to 10 new SLE children per year. The healthcare financing for our hospital and for several other hospitals in New Delhi is very varied. We have a fee for service in one area, and we have the national health system as a second tier. Now, our hospital has a 2-tiered system whereby the economically weaker sections of society are seen free, and the patients who are able to pay are seen at half-hourly slots in a daily paying clinic. The healthcare financing for the patients is usually by the family, as the healthcare insurance is held only by a fraction of the Indian population and currently covers only inpatient medical care. So we do not have any healthcare insurance funding for outpatient as yet. The health expenditure per capita is very low and stands at only $109 per person. We have a large number of adult rheumatologists to serve this population. So we have 10 rheumatologists in the National Capital Region. Our center is the only one that offers a dedicated pediatric rheumatology service, which is run by a pediatric rheumatology consultant. So we have all the NSAIDs available with us. We have steroids, but do not have the triamcinolone hexacetonide. As far as disease-modifying agents are concerned, all are available. In fact, India is the second larger exporter of drugs, and we have many, many generic molecules, so that we have low-cost generic hydroxychloroquine, azathioprine, mycophenolate. As far as the biologics are concerned, we do have rituximab easily available, and we also have a biosimilar which has been launched by Reddy's laboratory, which is called Redditux RA, which seems to function as effectively as rituximab, but is 1/4 of the cost. Now, how do we follow our children who have moderately active lupus? If the child is unwell, the child would often require an inpatient hospitalization. The febrile toxic patient would need close monitoring, and most often we would try and get down the disease activity by using intravenous pulsed solumedrol. Once the child is discharged, we would follow after a week, then fortnightly, and once we have a clinical stability, every 2 to 3 months. When we have a child with moderately active lupus, we would work to confirm disease activity by looking at the blood counts, the ESR, the C-reactive protein, the complement components, and also the double-stranded DNA. We would look at urine routine and a spot protein creatinine ratio every 2 to 3 months at least for the first 3 years. We would periodically look at the liver functions and the serum creatinine. And if the clinical situation demands, we would aggressively screen the patient for investigations and proceed for investigations such as a blood culture, a Vidal test for enteric fever, look for malaria, and also look very carefully for tuberculosis if indicated. Our routine testing for lupus would be done initially 2 to 3 weekly and then every quarter. Now, if we have a child with very sick, life-threatening lupus, this would obviously be an intensive care situation, and we would first assess the ABC for the patient, and we would most often need to treat in a double fashion, both looking at the lupus activity and also for infections. We would not try and use IV cyclophosphamide very often. If necessary, maybe just 1 or 2 infusions, and then we would try and follow up with azathioprine or Cellcept as the clinical situation demands. If, however, the child has not achieved a reasonable disease control, in 3 months we might even consider rituximab or cyclophosphamide for maintenance. The children would most often get oral steroids after IV solumedrol, usually at 1 mg per kg per day, and this dose would be continued at least for 4 weeks. When do we taper the medications? We would begin to taper the steroid dose only after 4 to 6 weeks, and we would use the disease-modifying agents per the clinical situation that we are being confronted with. The DMARDs would not be abruptly stopped, but would be tapered in all children. So in our scenario, what are the most important needs that we have to optimize the care of children with lupus? The first important need we have is early recognition of the disease, because I'm sure you're struck by the fact that even though the population is so much, we see so little, and what is the reason? Most obviously, we are missing these children. And for this reason, we need to introduce pediatric rheumatology postgraduate training programs which are currently not available in our country. Secondly, it is very important for the general physicians to recognize danger signs in these children and to be aware about newer modalities of treatment and help in basic pediatric issues as well, such as looking after the blood pressure, optimizing the BMI of the patient, encouraging the child to do exercise, and also looking at the regular blood levels and supporting the children through infections. And to this end, we need to organize regular updates for both the pediatricians and the physicians who may be seeing these children. We have a need of low-cost generic drugs and medical insurance for outpatient care so that care is easily available and affordable to all children. And to this end, we need to engage both the government and the drug controller. And finally, we need to have the children following up regularly and preventing patient dropout, which is very high. And for this, we need to have specialist nurses and to ensure a good follow-up. Thank you very much.